your gynecologist. I'm Dr. Sonal Parihar, and I really want to thank you all for liking my channel so much. The subscriptions that you've given me, and you're all sharing my videos, and the kind of questions I get every day, the enormous number of questions that I'm getting every day, that proves that you're really liking the channel. And I love interacting with you all. Every day I go live, I try to answer all the questions. Yes, I'm starting, like I'm trying not to repeat the same questions again and again, because I see that many patients ask the same question, probably because you're not listening to the videos properly. You're just waiting for your name and your question to come, right? So because many patients have a similar question, so now I have started avoiding those questions because it just wastes time. Okay, so please go through the video. Even if you are not live at that time, please listen to the video, the entire video, because it might just help you. The same problem that the problem of some other patient, some other person might probably occur in your life or in your friend's life or in your relative's life. So just give an ear, listen to it carefully so that you do not repeat the same questions again and again, right? One more thing, DocWise app is working very well. I have patients now all over India, not just all over India, even across in the world. The only problem with this app is that I do not have a calling option, right? Because the numbers that they provide us in this app can only be connected to the numbers in India, not outside. But they're working on it. Probably they will solve this problem. So it is like a WhatsApp app. You can send your reports. I can send you a voicemail. You can send me a voice message. You can also request me to call you, so I can call you at a convenient time. So it's working very well. This is my PIN. You can always connect through that. And these are the technical numbers in case you have any query. Then people who want to come to the hospital, this is the hospital address and the number and the secretary's number. Then what else? I have got other portals which is managed by either sometimes by me or by my secretary. Instagram, Facebook pages and Twitter. This is because some people are not very well versed with YouTube, and sometimes their questions get missed because of the enormous number of questions. You can always come on the Facebook pages and Instagram. If I feel I can answer it there, I will. If I think it's a very personalized question and I need to see the reports, then I will ask you to come on DocWise app. Right? So today's topic, as requested by you all, is premature rupture of membranes and preterm labor. Why I am combining both of them together? Because the causes, the risk factors and the complications are kind of same, because they're kind of interrelated with each other. Right? Now what is preterm labor? Preterm labor means when you deliver before technically 37 weeks of gestation. 37 weeks is said to be the landmark when the baby becomes term. So whenever it happens before 37, it is preterm. Now it has been divided into three categories. One is extremely preterm, that is less than 28 weeks, that is less than 7 months. In India, 28 weeks is generally said to be the age of viability. That is the age when the baby can survive because the lungs are mature enough for the baby to come out. Okay, although yes, it is quite premature, but still at 28 weeks it is said to be a baby. It is not said to be an abortus. Less than 28, it is generally referred to as an abortus. Okay, so extremely preterm. Then comes very preterm. Very preterm is between 28 to 32 weeks. That is 7 and 8 months. 7 to 8 months, right? And then comes from 32 to 37 weeks when it becomes a moderate preterm. That is, it is not very risky to basically deliver at this age because the weight is good, the lungs are quite mature enough. Although technically I would say practically 34 to 35 weeks is the ideal time when we say that the baby is out of danger, even though it is premature, even though it is preterm technically, but 34-35 weeks is the time when we do not worry much that the baby is coming out of the womb, right? So these are the three categories. Coming to PROM, now premature rupture of membranes means when the water leaks, the water bag bursts before the onset of labor. So that is premature rupture of membranes. Now again, PPROM is a technical term which means preterm premature rupture of membranes. So it is a combination of preterm as well as premature, right? Premature means before the onset of labor, but the patient is technically term. She has crossed 37 weeks. When it comes preterm premature, that is, it is happening before 37 weeks. So it is a preterm rupture of membranes, right? Now, it's confusing, right? Now, these two things, they go hand in hand. What are the risk factors? Now, risk factors, if we actually, or the causes you can say, if we divide them into 4 categories, first would be history, right? Whenever a patient walks in, whenever a pregnant lady walks in, we take a proper history and we ask her, have you had a preterm labor before? Have you had a premature rupture of membranes before? Any infection, any blood pressure problems, any diabetes? All these things go like, they put a patient in a high risk category. Sometimes you people ask me, ma'am, I've had a miscarriage in the previous pregnancy, will this happen again? Yes, because if you have this history, you are put in that high risk bracket, right? So we have to be very precautious. It can be anything. It can be a preterm labor, it can be a miscarriage, it can be bleeding. Anything which you have had in the previous pregnancy can repeat in the second pregnancy. Okay, so this is history. Second comes the maternal causes in this present pregnancy. Now in the present pregnancy, if the mother is underweight or overweight, if the mother has nutritional deficiencies, she is not fit enough to carry the pregnancy, or the mother is suffering from some systemic disease like liver disease, kidney disease, or diabetes, or she's having high blood pressure, it can be essential hypertension, or it can be pregnancy-induced hypertension, which is called PIH, preeclampsia. I'm going to very soon make a video on that as well. Then she might be carrying 2 or 3 babies. It can be a multiple gestation. So multiple gestation makes you more prone towards premature rupture of membranes and preterm labor, right? She might be having lots of fluid inside, that is polyhydramnios. Again, that makes you more prone towards premature rupture of membranes and preterm labor. What else? Well, she might have undergone an invasive procedure like amniocentesis, or she might have had a circlade stitch done at 12 or 13 weeks. Now, circlade stitch as such is very safe, but yes, it is an invasive procedure. It sometimes, maybe say 0.1%, it does give you a chance, it does put you in the risk of having a preterm labor or a premature rupture of membranes, especially when it is done in an emergency. Many patients who come in an emergency with dilated cervix, we just kind of put a stitch just to protect the baby so that it doesn't come out, and we try. It's a trial. So in such cases, we might rupture the membrane, so I put in the stitch, or the patient might go into preterm labor, right? So these are the causes, the maternal causes which might happen. Or yes, one more thing. She might be having some kind of infection. It can be infection inside the womb, chorioamnionitis, or it can be urinary infection, or it can be any kind of infection elsewhere in the body. That might give her preterm, premature rupture of membranes or pains, right? Intestinal infection, any kind of salmonella infection, any kind of tuberculosis in the intestines, any kind of intestinal infection might give her the crampy pains and might lead to infection in the uterus, giving rise to the complications, right? Third category would be an abuse. Now the mother, if the patient is taking drugs, is taking tobacco in the form of smoking or just eating tobacco, or she's addicted to alcohol, she's an alcoholic, or she's taking IV injections in the form of drugs or whatever, all these things make you more prone towards preterm labor because your body is not fit enough, you are not having proper immunity to carry the baby for 9 months, right? Next comes the fourth category, and the fourth category means anatomical problems within the uterus. Now the uterus might be double in the form of bicornuate uterus, or uterus diadelphus, or it can be just a septate uterus. I have already explained this thing in my video on bicornuate uterus. So whenever there is an anomaly inside the uterus, the amount of space that a baby gets inside the uterus to grow is less. So obviously such patients are more prone towards preterm labor or premature rupture of membranes. Such cases generally go hand in hand with cervical incompetence. So the mouth of the uterus, which is called cervix, might be incompetent. This might lead to premature rupture of membranes as well as painless preterm labor, right? So many patients come with a history that suddenly there was a gush of water and the baby came out without any warning sign. There was no pain at all. So this might be because of cervical incompetence, right? So these are the risk factors for preterm labor as well as premature rupture of membranes. For premature rupture of membranes, sometimes I would say there are other risk factors in the form of bleeding in pregnancy. Sometimes when the patient is bleeding in pregnancy, suddenly she might just break her membranes because the tensile strength of the membranes is not enough, right? Then there may be some infection inside, which I have already discussed. Then there might be some placental abruption. The placental abruption means sudden separation of the placenta. So that can be a cause of premature rupture of membranes, or it can be a complication of BPRM. It can go either way, right? Then coming to the complications. Now first I will discuss premature rupture of membranes. Now if the patient comes with premature rupture of membranes, what does the doctor do? Now it depends at what gestation she is coming in. If she comes at say 36 weeks, 34 weeks, not a problem. She might just go into labor spontaneously. It has been seen that whenever there is a premature rupture of membranes, within 24 hours the labor sets in and the patient delivers. So after 34 weeks, it's not a big problem. Before 34 weeks, especially if it is in the 6th month or 5th month or the 7th month around 27-28 weeks, then the problem arises, because at that time the baby is not mature enough to come out, and we cannot keep the patient continuously for 3 months in the hospital. She's leaking. We know that the membranes have broken, that the water bag has burst, and once the bag bursts, we cannot restitch it. It will never come back again, right? So what will the doctor do? Well, the doctor will give you betamethasone or dexamethasone injections, because we know that the baby is eventually going to come out prematurely. So we want the lungs to develop, because these lungs, when they are inside the uterus, when the baby is inside the uterus, it is swimming like a fish. They do not expand with air. There is no air inside. But these lungs, they develop in that water. So the lungs need to develop in the water, so that when they come out, they can feel air in it and they can expand. So if the premature rupture of membranes happens at a very early age, then we have to give you steroid injections. Two doses are given, normally 24 hours apart, or sometimes in an emergency it can be 12 hours apart. Then we need to exclude infection, because if you have to carry the baby with ruptured membranes, which acts as a barrier, then you have to have antibiotics to prevent infection, to prevent complication to the mother as well as the baby. Okay, then it depends what gestation you are in. You might be kept in the hospital, you might be sent home. There are certain procedures like filling your uterus with some warm fluid in the form of drip. This is when the patient has to be transferred with the baby inside to some tertiary center, because it is temporary. The water will not stay. If the membranes have ruptured, it will come out. Right? So these are all temporary methods, but generally antibiotics and betamethasone, dexamethasone are the main stay of treatment, plus bed rest, avoiding heavy work, and keeping the patient with leg end raised. Either you can keep pillows inside below the buttocks, or you can just raise the leg end of the bed, so that the fluid doesn't leak and there is fluid left inside for the baby to grow. Right? Now, what complications do we expect from this? If there is a premature rupture of membranes, the complications to the baby would be pulmonary hypoplasia. First of all, pulmonary hypoplasia occurs if the rupture of membranes happens at a very early gestation, say 5th month or 6th month, and somehow the baby is able to survive till the 9th month. So these babies have a complication, have a chance of developing pulmonary hypoplasia. That means their lungs do not develop. As I said before, when the fetus is inside, it swims like a fish, so the lungs have to expand. So if there is no water which helps in the expansion of the lungs, then the lungs will not develop. So that's called hypoplasia, and that is a very dangerous complication. Second thing, many ladies, they deliver babies with club foot or equinovarus foot. Now that happens because when there is less fluid, then the baby just kind of gets compressed inside in between the uterine walls. So sometimes it might have skeletal deformities. The hand might go like this, or the feet might go in the club form. So these things can be corrected to some extent. Depends what kind of deformity it is and how extreme it is. The orthopedic surgeons, they normally deal with it. Right? So these are the fetal complications. To the mother, if there is a loss of fluid at a very early stage, then infection might set in. Chorioamnionitis, she might have infection inside the body. She might even have placental abruption, which I just told some time before, that premature rupture of membranes can suddenly the gushing of water gives a lot of pressure on the uterus, so suddenly the placenta can separate, and that can be horrendous, that can be dangerous for the baby as well as the mother. So these are the complications of premature rupture of membranes. Now, if the preterm birth occurs, if the baby comes out before 37 weeks, what all complications can we expect? Well, as you know, if the baby is premature, the lungs are premature, the lungs will not develop, that means the baby will need respiratory support, there will be problem in the respiration. Then some babies have less oxygen supply to the brain. Now this might happen during delivery, depends what kind of delivery it was, depends when the patient reached the hospital. She might have suffered an insult to the brain of the fetus, less oxygen supply to the fetus inside the uterus itself. It might be there for a couple of days. So such babies, they develop with cerebral palsy. Now we don't know why the cerebral palsy has occurred. We know the cause, yes, because there was less oxygen supply to the brain, but we do not know when this happened. Okay, so such babies might not develop very well. Their milestones might be delayed. They might develop mental retardation. Then necrotizing enterocolitis is again one of the very major and dangerous complications in which the intestines of the fetus undergo necrosis. Then what else? brain problems I've already told you, pulmonary I've already told you, then infection, such babies are underweight and their milestones are delayed, they might not be that intelligent, and they are more prone to infections because they might suffer from nutritional deficiencies. You must have seen premature babies, they are kept in a machine which is kept warm because such babies cannot maintain their temperature also. Their skin is not mature enough, their body circulation is not mature enough to give them enough warmth. And such babies sometimes they require a lot of nutritional support, not just mother's milk but other kind of supports as well. Right? So it is very dangerous, and I would say it's very common, and we are trying as gynecologists, we are trying to reduce the rate of preterm labors, and we are trying to develop nurseries, good well equipped nurseries, so that such babies do not suffer. Right? So friends, I think this is all you need to know about preterm labor and premature rupture of membranes. If you have any queries, if you want to share your history, your reports, you're always welcome on the YouTube. I go live every day and I answer your questions. Till then, take care and keep watching my videos, keep sharing them, keep sending me the topics so that I have a list of topics on which I make videos every Wednesday and Sunday. Right? So take care, bye bye.